Jonathan, you had said that the incentive, like what's really the incentive for PTs to learn the value-based care world, even if we're not in risk models, right? Even if, as of right this moment, as we're building and growing and sort of changing the perception of the profession, what should be the incentive? How should we think about this? One of the things that you said was you become the go-to clinic. So can you just talk a little bit more about that? Because I think if we can give some tangible, even though they're kind of softer things, some tangible, like how can this benefit me in this year, for example, even if I'm not taking financial risk and I'm going to see a check at the end of the year, what day to day, month to month is going to benefit me or my clinic?
Sure. So we spent a lot of time talking about, I think, what the difficulties are when you're trying to go get provider partners, get providers to trust you. But I will say from my perspective as a clinic manager, one of the hardest challenges I face is how do you convince your team to do a little more work is what it seems when you're not going to be paid any more money than the person who's not. Like, what's the incentive there? And we have a really relational crew. We tend to care a lot about each other in this building. And so for us, a lot of times we get a student that we really, really liked, was a great fit, but like, sorry, we don't have enough volume to bring this person on. Or, this person really wants to work here, but we don't have a spot because we just don't have more volume right now. We're kind of maxed out. So I think when you can position yourself as you're speaking the same language as these providers who are in these ACO agreements, you understand whether you're necessarily contributing directly to their bottom line or receiving any of that money at the end. When you understand what their mission is and what they care about, and you can speak the same language, they're going to trust you more than anybody else, and they're going to send you all those patients, and I've never gone and said, hey, send us more referrals. But we start getting more because we understand what they need from us and how to help them. So all of a sudden now we're the go-to clinic for XYZ provider because they know we're going to deliver a product that is consistent, that they can trust, and that ultimately is best for the patient. And then, on our side, then what happens, a benefit for us is now we're busier. Now we have more volume. So now we need more people. So all these people we care about and want to be part of our team, we can support those people and bring them on and create these positions. And we've seen that play out a couple times.
And I would say that just to kind of take it one step further, you may have to point this out to the powers that be that care about this. But in the short term, it might be that you're improving the fee-for-service utilization of physical therapy, having your department become a larger source of revenue. So you're demonstrating, right, to the system or whoever the owner is or, whatever the setup is, that you can bring in more revenue. That's what we want in the primary care type providers. We want a system where more good work is being done by physical therapists and PCPs and mental health providers. And why is that good? Because it's going to reduce by nature, because we're doing more upstream and we're engaging people and all the things we talked about. They're less likely to use the ER as a source of care or specialists that you don't collaborate with, that we don't know, like the type of care that they provide. They're less likely to go off and find somebody to order imaging. So it's really good for your department to be doing that first even on the fee-for-service side. We want that. That's the fee-for-service that's good. We may not have all the billing codes that we should have. That's another story. But if you to your point, you're doing more work, you're getting more patients. While I'm sure your system would rather see them with you than with an outside organization, that's right. Everyone would like to keep it internal. But then you're also helping the ACO, for example, who's trying to avoid a lot of that, downstream utilization. So, but you may have to point that out. In the beginning, it's, we're able to offer more, provide access, and we're building this relationship. What's resonating when you talk about that, Jonathan, is, practices hire salespeople to go to physician practices and build relationships. They're not doing anything different, really, than you're doing. You're trying to develop organic communication and trust building because people change behavior because they want to do something different. Change is really hard. So if you're expecting a change in how a provider that maybe in your community talks to their patients about therapy or how much effort they put into sending them to you, that's going to come because of a relationship. And salespeople know this. You're just cutting out the salesperson. and you're just building the relationship, it's a good thing.